Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchette. Today's episode features coverage of the 2020 International Congress on Drug Therapy and HIV Infection, also known as HIV Glasgow 2020 Virtual. During this podcast, Dr. Renslow Sherer from Chicago, Illinois, will discuss important new data presented at the conference, including new findings on long-term 2-drug and 3-drug antiretroviral therapy, the efficacy of newer 3-drug regimens in patients with baseline NRTI resistance, the latest information on investigational HIV treatment approaches, and updates on important comorbidities in patients with HIV, including COVID-19. For more information on Dr. Sherer and for a link to additional online CCO coverage of HIV Glasgow 2020 Virtual, including a downloadable slide set covering the studies discussed in this episode, please visit the show notes. Now let's get started and hear what Dr. Sherer has to say about these new data.
Thanks, Jen. Thanks to everybody for joining today. I was telling Jen, I think this is the fastest turnaround for a conference review I've ever been involved in. It ended last night. And here we are providing a review. And I just want to say Glasgow is one of my favorite annual meetings. I'm very sorry it was only virtual this year, though they did a spectacular job to pull it off. And I'll hope, like all of us, that we're able to convene sometime in the future, in the year or two maybe, with real meetings together. And I want to share the hardest piece of information from the conference was the news from Brazil that one health worker is infected with COVID-19 every minute currently in Brazil. And I say that then hoping that all of you listening are taking care of yourselves and your family. I hope that you haven't suffered from COVID, and those who have, I'm so sorry for the losses. And I'll look forward with all of you to a better time when we have a much better handle on this epidemic. Okay, so meanwhile to work, one of the most interesting studies I think at the meeting was the long-term follow-up of 144 weeks of the Gemini 1 and 2 analysis of the 2-drug regimen, dolutegravir plus 3TC in comparison to dolutegravir, FTC, TDF in drug-naive patients. And this was a large registrational phase 3 trial with over 700 people in both arms. And you can see in the pooled analyses that 84 and 82% of people were suppressed. The non-inferiority criterion for the 2-drug regimen was easily satisfied by both study independently and then by those who were pooled. You'll remember that these were folks who were enrolled, randomized 1-to-1. They had to have no hepatitis B, no initial mutations to either the integrase class or the nucleoside class, and to have an entry virus load less than 500,000. So if we think about our concerns for long-term for the 2-drug regimen, we're thinking about durability, potency, resistance, and toxicity. And so this certainly provides assurance in overall durability of virus load suppression. So let's go a little bit further then and look at, first of all, the snapshot analysis showed, you see the 82 and the 84%. For those that were over 50 copies, you can see very few discontinuations for lack of efficacy or for other reasons. And a similar proportion, about 15% with no virologic data at the time that the analysis was closed. So for those who met a confirmed virologic withdrawal, that CVW, which is this study's definition for virologic failure, it was only 2% in the 2-drug arm compared to 1% in the 3-drug arm. I don't think that's a clinically meaningful difference. And there were no emergent resistance mutations to either the integrase or the nucleoside class. And then I think very importantly, the investigators disclosed one patient in the dolutegravir 3TC arm who actually didn't meet the confirmed virologic failure, virologic withdrawal criterion, who had non-adherence, who developed an N184V in the 132nd week, and then at week 144 had an integrase mutation, which resulted in a 1.8-fold change in dolutegravir susceptibility. But that patient had good virologic suppression when later switched to a dolutegravir plus a boosted darunavir regimen after week 144. And I think this is not surprising. We've seen the beginnings of, even with the second generation integrase inhibitors, where there's prolonged poor adherence, they are susceptible over time to the development of drug resistance. So it certainly is not a surprise. One person out of 716, I think, probably corresponds to what we've seen in the initial clinical trials with the second generation integrase inhibitors. Looking at safety, weight gain, and virologic response, there was a lower risk of drug-related events in terms with the 2-drug regimen, 20% overall compared to 27% with the 3-drug regimen. There was more weight gain with the 2-drug regimen, 3.7 kilograms as compared to 2.4. We've certainly seen this with other studies that dolutegravir, that TDF combined in a regimen is a little more likely to be associated with a lower degree of weight gain than those that are TDF free. And then if we look at the variations by either subgroup with over or less than 100,000 baseline virus load, there was no difference, importantly. We did see a signal in those who were less than 200 CD4 cells for lesser performance in both arms. So 67% achieved virus load below detection in the 2-drug regimen compared to 76 in the dolutegravir FTC TDF arm. And that certainly might lead a clinician to be a little more conservative about the use of the 2-drug regimen in those with the most severe disease as measured by T cells less than 200. The lipid, renal, and bone changes were as you would predict and as has been seen in the phase 2 trials. That is, there was an increase in lipids in the TDF sparing regimen, the 2-drug regimen, as we've seen in other studies. So lipid parameters actually are a little bit worse simply because of the loss of the lipid suppressive effect of TDF. And the kidney parameters were improved with the absence of the tenofovir kidney impact. So the take-home message, as you see at the bottom on the right, the cholesterol parameters were better on the tenofovir-containing regimen, but renal and bone parameters were worse. All right, so we're going to keep going then with this 2-drug regimen and look at the Tango study. This is a different clinical setup. You'll remember that Tango was a comparison of switch to the regimen of dolutegravir 3TC from a variety of other regimens that were TAF containing. And this is the investigators reporting on the 96-week switch data. You can see overall that there was a comparable degree of virus load suppression that was actually favored the dolutegravir 3TC arm, where 86% of people were below the level of 50 copies compared to 79% in those with TAF-based regimen. So the primary endpoint clearly made non-inferiority with very narrow error margins. And there was actually a suggestion of superiority in the secondary endpoint, which was the degree of those who had achieved a less than 50 copy threshold, favoring the 2-drug dolutegravir 3TC arm. And again, I'd remind you that these were individuals who, in order to get into the trial, had to have an absence of either NRTI or integrase mutations at the time of entry into the study. This is what that looks like when we break it out in terms of all of the different criteria for the clinical trial. There were no cases of confirmed virologic withdrawal in the 2-drug dolutegravir 3TC arm, whereas there were 3 among the TAF-based regimens at week 96, and there was no resistance detected among any participants with confirmed virologic failure. Moving on to the lipid and renal parameters, they were very familiar and as described. So overall, drug-related adverse events were 6% compared to 2% respectively for the 2 and 3 drug arms. Discontinuations related to adverse events were 4% and less than 1%, and really very little difference overall in terms of safety. And as we saw in the previous trial in Gemini, there was actually a worsening among the lipids. So in the dolutegravir and 3-TC arm as compared to the TAF-based regimen. But and renal and bone markers also were actually quite similar. Let's move then to another study. This is the switch to the bictegravir, FTC, and TAF study that was presented by investigators at Gilead Sciences. This was a meta-analysis of 6 different studies of clinical trials in which patients who were virologically suppressed were switched. You can see the different entry criteria for those studies. Some of them explicitly allowed the presence of resistance mutations in the M184VI, and others did not. And this is an interesting study that will help us to understand a little bit more the predictive value of the proviral DNA genotype, which was used to help investigators to make their decisions. And across the studies, there was no emergent resistance in any of these clinical trials. So this shows us the baseline resistance mutations in this particular study, and you can see overall that the nucleoside resistance mutations were present in 16% of the study population, and these total of 2,000 enrollees in these 6 clinical trials. Non-nucleoside resistance mutations were present in 22%, protease-resistant mutations in 11%, and even 2% had integrase resistance mutations, although they were not supposed to be there. And pre-existing M184V was more likely to occur in patients with older age, with Black race, who came from the United States, and who had other resistance mutations. None of those are really very surprising indications. So I think this is a very educational slide. It's worth taking a moment. What you see on the far left is the information that the investigators had from the known historical genotype. And then in the middle is the results of the proviral genotype. And you can see quite a bit of different information. So here, when in this case, in the first study where there were 37 known patients with an M184V, the archetype proviral genotype only showed it in 59%, where the remainder found wild type. So this is a good lesson in the use of the proviral DNA genotype. It often misses a known existing mutation. In those patients who were thought historically to have wild type M184V, 5% of them were actually found on their archive genotype to actually harbor M184VI. So sometimes it can give you additional information that you were lacking. And then there were 330 patients where there wasn't good data regarding the historical genotype, and they found M184V in 13% of those, and et cetera. It was also true when they thought that they were taking care of patients with no resistance mutations. In any event, so that's a lesson on how to interpret those archive genotypes. If you find a mutation there, you have to take it seriously. But if it's negative, it really does not rule it out. A negative is not very useful information from that study. In any event, it turns out it didn't matter at all in these switch studies. There was uniform excellence virus suppression between 97 and 100% if they had the M184V, if they had none, if they had M184V plus other resistance mutations, other non-nuc mutations, PI mutations, even those who had M184V in the K65R, that was 8 patients, or other TAMs, that was 70 patients, everybody had full virus load suppression. There was also a lot of interest in Glasgow in the combinations with the newest NRTI, doravirine. Drive Shift, you may remember, was a switch study that took folks who were controlled on a variety of different regimens with stable ART for more than 6 months, who had an EGFR greater than 50 mLs per minute, and no previous virologic failure, no known resistance to the study drugs. And they were randomized to either receive the new study drug, doravirine, co-formulated with 3-TC or TDF, or to remain on their baseline treatment for 24 weeks. They were then switched for 24 weeks to the 3-drug regimen, doravirine, 3-TC, and TDF. And then that was allowed in an open label extension to go all the way out to 144 weeks. And so this is the report of the result of those 144-week data. And you can see the degree of virus load suppression is excellent, with 91% suppressed in those who switched immediately, 95% in those who delayed the switch. And so we'll look a little bit further at some of the safety and outcome analyses. Here's the more detail on the efficacy. You see the 80 and 84% who achieved the less than 50 copy threshold. Change from baseline in CD4 cell counts was an increase of about 40 to 55 cells. For protocol-defined virologic failure in the first 100, from baseline to 144 weeks, you can see it was 9 and 7 patients, or 2 and 3% altogether, and very few new virologic failures following week 49. There was no resistance to either doravirine or to the nucleosides class in this study, and including no resistance in those patients who discontinued medication. So one of the advantages that's being seen and appreciated with this particular co-formulated regimen is the improvement in lipids. We've seen already that TDF is associated with lipid lowering, and doravirine certainly seems to only help when they go in that direction. So you can see overall decreases across the board in the lipids, with 20 to 30% reductions in cholesterol, 20 to 15% reductions in LDL cholesterol. And actually, one of the biggest impacts was in triglyceride, with 30 to 40% reductions. And you see in the darker green week 24 outcomes and week 144 outcomes in the lighter green. So certainly one of the more interesting features of this regimen is its impact on weight. You can see by 144 weeks that the weight increase overall across this trial was between 1.2 and 1.4 kilograms. There were very few discontinuations due to adverse events, 4% overall. Serious adverse events occurred in 10% of individuals, and there were no deaths during the course of the trial. The most common adverse events that have been reported with this 3-drug formulation are nasopharyngitis at 16%, headache at 12%, and diarrhea at 9%. So there was also one, I think, important patient, the case report that made it all the way through and was accepted as an abstract at this meeting, simply because it described a phenomenon that's been so rare, and it corresponds to one we've already talked about in earlier trials. And so this was a patient reported from Germany with treatment-emergent integrase resistance following the use of first-line bictegravir, FTC, and TAF. So the patient was a 48-year-old woman hospitalized in Hanover in Germany who has subtype C infection. She had some polymorphisms at baseline in the integrase class, the M50I and the S119P, but no resistance mutations that are confirmed for the either integrase PI or RT substitutions. She presented with advanced disease with over 2 million copies in her virus load and 75 CD4 cells. So she had advanced disease, but no baseline resistance. Started on the bictegravir FTC TAF regimen, and within a fairly short time developed PML with neurologic difficulties, and then a history of problems with adherence all the way through her clinical course, such that in October, with ongoing episodes of viremia, and you see, although the CD4 cells got as high as 400, the lowest her virus load got was 200, and then 700 and 1,000. And again, a story of variable adherence during this time. And then in January 2020, she developed both M184V and integrase resistance mutations. Then was switched onto the boosted darunavir combination, unfortunately continued with viremia, and then has been seen to have other emergent resistance mutations. So here again, I think this is a similar lesson to what we saw with the 2-drug integrase dolutegravir containing regimen earlier in this presentation, that with ongoing viral replication and with poor adherence, we do see that there can be susceptibility to the development of drug resistance, even with our second generation, these excellent integrase inhibitors that have such a high genetic barrier to resistance. if there is ongoing viremia in the presence of poor adherence, a resistance mutation certainly will occur. That brings me to part 2 of our presentation, and this is to look at some of the investigational treatment strategies. There certainly is a lot of excitement in the field for some of the upcoming treatment regimens, in particular those that are involving long-acting. And so certainly one of them is the long-acting formulation of the integrase inhibitor cabotegravir with the non-nucleoside inhibitor rilpivirine. And these were the 96-week results of FLAIR. This was the head-to-head comparison of cabotegravir and rilpivirine injected every 4 weeks with daily dolutegravir/abacavir 3TC in treatment-naive patients. And just to walk through this structure, patients had to start initially with dolutegravir/abacavir 3TC, and these are drug-naive patients with detectable viremia over 1,000 copies per milliliter, who were hepatitis B surface antigen negative and who had no NRTI or integrase mutations. And it was a total of 629 patients. And they were randomized either to stay on that oral regimen of dolutegravir/abacavir 3TC up until week 100, or to switch to an oral regimen of cabotegravir/rilpivirine for a month, and then at 4 weeks to switch to the injectable if they had tolerated it and were otherwise still undetectable. And so we're looking here at the 96-week results. And the other thing that I should point out is those who were put into the dolutegravir/abacavir 3TC arm for the first 100 weeks then were allowed to switch into the long-acting cabotegravir/rilpivirine injections. And they switched in one of 2 ways. They either went immediately the DTI or direct to inject route, or they went through another 1 month oral lead-in and then took the medication. So these were the overall virologic outcomes. It was exceptionally successful. 99% of people in the direct to inject were controlled as compared to 93%. So spectacular results on both sides, with breakthrough viremia only in 1 patient in both group, 0.9%. And there was no incomplete data in the direct to inject and only a handful in those who were part of the oral lead-in. Certainly one of the concerns and the reasons for this comparison for the oral lead-in and the direct to inject is, would the pharmacology allow for just immediately going from the oral dolutegravir route without going through the oral lead-in with rilpivirine and dolutegravir? And you can see these are historical comparisons for the oral lead-in as compared to the doses that are achieved with direct to inject. These are levels of both dolutegravir and rilpivirine. And you see really no difference at 1 week and 4 weeks post-dose. So fortunately, the pharmacology and the clinical outcomes, virologic outcomes, are supporting the justifiability of going straight from dolutegravir/abacavir 3TC into injectable cabotegravir/rilpivirine. There were no fatal adverse events. You can see in this group, any adverse event was pretty common, but no liver monitoring or stopping events were required. There was no hypersensitivity, no dermatologic manifestations. And so what was seen in FLAIR was what was reported early on, which was injection site reactions and pain at the site in about 1/3 of patients. And I think if you're familiar with the other FLAIR results, these are enormously popular trials. Most of the patients, the majority of patients, have said, having gotten into this and gotten this far, even with injections every 4 weeks, their intention is to continue with long-acting injectable. And of course, I think there's a comparison study in the Atlas trials that have looked at every 1 month compared to injections every 2 months and shown comparability of outcomes and toxicity. So let me switch gear then and then go to another experimental medication, islatravir, which is the novel NRTI, meaning nucleoside reverse transcriptase translocation inhibitor, which is being paired with doravirine in some thoughtful clinical trials. In this trial, P011, this is the presentation of the comparison of the 3-drug regimen of doravirine, 3-TC, and TDF to the 2-drug combination of islatravir and doravirine. So this is a phase 2 study, and this is how it was structured, with 3 different doses of islatravir in combination with doravirine and 3-TC for the first 24 weeks, and all of those were compared to the 3-drug regimen, doravirine, 3-TC, and TDF. That arm continued into the second phase, and in the second phase of study, all of people in the 3-drug regimen with doravirine, 3-TC, and islatravir were then switched with 3-TC was taken off that regimen, and they were left alone with different dosing formulations of islatravir plus doravirine, the 2-drug regimen, once a day. And to get into this trial, you had to be drug naive, over age 18, have detectable virus load over 1,000, and T cells over 200, have no resistance to either class of drug, and no either active hepatitis B or hepatitis C. And these are the results. Very good drug suppression at the 2 lower doses. It was 86 and 90% of individuals maintained virus suppression throughout the 96 weeks. An interesting signal of lower performance at the highest dose level of 2.25, and a higher frequency of virologic failure in the highest dose, and that's being investigated further. It appears that the drug dosage for moving forward will be the 0.75 level, and you can see that some of this, a fair amount of this may have just been the lack of virologic data in the window for that particular cell. When it comes to protocol-defined virologic failure, you can see rebound with greater than 50 was present in a very small percentage, between 3 and 6%. In none of those cases was it greater than 200. So in each case, this was a blip or a viremia between 50 and 200 copies per ml. Looking at adverse events through week 96, which is of critical importance in a phase 2 study, you can see the frequency of any adverse event was in the range of 80 to 90%, but serious adverse events were very uncommon, in the range of 3 to 10%, leading to discontinuations in none of the patients in the lower arms, and only infrequently in the other group. If I were to point out something to pay attention to and watch in future, I think it's that there seems to be a signal of CK elevation. You can see 4 out of the 29 patients, or 13%, had a grade 3 CK elevation. This is in the absence of any clinical signs or symptoms of muscle toxicity. And so that's something I think that we'll be watching as we go forward. But I think this is a very exciting potential compound, both as a 2-drug regimen, and then I'm sure you've seen other instances of islatravir with its unusual pharmacology, allowing as anything from weekly doses to even longer periods of time with the use of implants. So I want to turn now to comorbidities that were discussed at the Glasgow conference. There was a very thoughtful presentation from the group at the Medina HIV Metabolic Clinic from 2007 to 2019. So this was an observational study of people who were integrase naive, and you can see the color code that we'll follow is in this teal color. That's the integrase naive, or anyone who had switched to an integrase during this time, and looking at the question of weight gain, fat distribution, and fat density. And you can see the baseline nadir CD4 cell count was significantly different. It was higher 210 in the integrase naive group compared to those who had been switched. That was 150. So in this study, what they did longitudinally over a 4-year period was to measure body composition at first visit and the most recent visit to look at weight gain. And then this was a very intense analysis comparing people who had never gained weight to those who had gained 5% or more, using DEXA and CT scan, doing studies on subcutaneous fat and visceral fat, and looking overall at EAT density and psoas muscle density. And you can see the overall follow-up of around 4 years in both groups. So this is a very busy slide. It's challenging, I think, for everybody. So I'm just going to walk through it by going slide to slide. you can see overall that there was a significant difference in the BMI. So there was a higher BMI in those patients who had switched to an integrase, and overall the prevalence of obesity was pretty low. And just to refresh your memory, that was in the range of 11 to 14% in this cohort. The next study result was that weight gain was similar in these two groups and was mainly driven by fat gain. We also saw that there was fairly high visceral adipose tissue, but it was not different between the two groups as whether they had never had an integrase or they had switched to an integrase. And there was a suggestion, a trend towards higher subcutaneous fat increase in those who had switched to an integrase. There was a similar reduction in the liver to spleen ratio in both groups, not of clinical significance. And there was a significantly greater increase in VAT, visceral fat density, in those who had had an integrase switch, and a similar decrease in subcutaneous density in both groups. And the investigators wondered if that was actually, there was evidence of an improvement in the overall quality of the fat. So trying to summarize this, so in the 4-year follow-up period, people with HIV who had gained weight of 5% or more, who switched to an integrase inhibitor, experienced larger BMI increases compared to those who had stayed integrase naive. So there does seem to be this association both with weight gain and a propensity for increasing BMI. Mostly the BMI increase was driven by subcutaneous adipose tissue, but there were not differences seen in ectopic fat deposits, and that's, I think, a very important distinction between this phenomenon and what we've seen earlier with lipodystrophy. And the visceral adipose density differences that were associated with switching really do not suggest metabolically abnormal fat. And so again, the investigators wondered if this had to do with an improvement in overall tissue quality and suggested that there was more research that needed to be done on that issue. And I can guarantee that there are, because the more we learn about fat increase, the more difficult it is to understand all the many features that are associated with it. We've certainly identified multifactorial reasons for fat increase. If we review them, a switch from TDF to TAF is associated with a 2 kilogram weight gain. The integrase class is associated with weight gain more than the other classes. And within the integrase class, it seems to be most strikingly high for bictegravir and dolutegravir compared to the other integrases. Still, I don't think those are necessarily of great clinical significance, but something to talk to patients about. But then we see that certain subsets of patients, particularly African Americans and African American women, do seem to be susceptible to the greatest increases of 5 to 10 kilograms over a 2-year period, and that may actually require additional intervention. All right, so let me turn then to COVID-19. We can't escape a meeting now without talking about COVID-19. This was, I thought, a very well-done study across the United Kingdom, looking at 47,000 people with COVID-19 at 207 centers. This is largely the same collaboration that brought us the information about the recovery data and the survival advantage with dexamethasone. So in this analysis, they identified 123 people with confirmed HIV, and so they were able to compare those 123 patients to the 47,000 without HIV, just to describe what are the kinds of differences that are seen. And I'm sure you could predict what we would see. Certainly you'd expect there to be younger age, and that was true. The mean age was the median 56 compared to 74 years. There were more men and fewer women in the group with HIV as compared to the general population. There were fewer whites and a larger representation of people of color in those with HIV as compared to the general population, as we've seen in other comparisons in the UK, and a greater likelihood of, interestingly, of non-smoking. That's probably not what we would see here in the United States, and of former smokers. And also, interestingly, there was an average of 2 comorbidities in the COVID patient population in the UK, and only 1 among those who had HIV. So because they're younger, a tendency towards lower comorbidities. Those that were comorbidities less frequently associated with HIV included chronic cardiac disease, pulmonary disease, dementia, malignancy, rheumatologic disease. But where they were similar was asthma, chronic renal disease, diabetes, hypertension, chronic neurologic disorder. And I think, again, this just has to do with the differences in the baseline patient population. The overall cumulative mortality favored people with HIV, so it was 27% if you had HIV compared to 32% if you did not. So you were a little better off. But if you then age stratify that information, what you see is if you're under age 60, your 28-day mortality is significantly higher with HIV, 22.4% compared to being without HIV. So, and that was also true for a greater likelihood of admission to critical care if you had HIV as compared to not. And I think that corresponds to data that we've seen also from the VA cohort in the United States, where overall we did not see an association between more severe disease and people with HIV. And that was in the VA cohort, 80% of those people were well controlled. So this is our last study. I'm happy to say this was our presentation from the University of Chicago. And what we saw in our retrospective chart review, this was done in the first 400 patients on the ID COVID consult service at University of Chicago in March and April. We did a comparison looking at those who met a definition of severe illness using the same criteria that's been used in the remdesivir trials and the tocilizumab trials, defining severe COVID as those who needed high flow oxygen, a positive pressure device, or intubation and mechanical ventilation. And death was all-cause mortality was included in this definition. So in our patient population, we saw a median age of 60. 90% of the patients that we served were Black and African Americans, and they came, 3 out of 4 patients came from the South Side. We had the usual smattering of treatments with hydroxychloroquine, and about a third. Our principal investigator, Kate Mullane and Dave Pitrak at UC, worked very hard to enroll people in the remdesivir trial. So almost a third of patients received remdesivir, and 9% received steroids. And our overall mortality at 30 days post-discharge was 13%. And we saw, as others have reported, that comorbidities associated with severe illness included hypertension, diabetes, chronic kidney disease, congestive heart failure, and in the multivariate analysis, that obesity was also included in that. But our report here was really about this cell looking at patients with past or current cancer and those who are otherwise immune compromised. And what we saw is shown in the title that in HIV, cancer, transplant, or people receiving immunosuppressive therapy, so this large group of people with immune suppression, that was not associated with severe COVID illness, not individually or not in aggregate. But we did think in this group that the mortality of 13%, you could see in some of the other presentations that compares favorably to initial hospitalization mortality rates that are anywhere from 15 to 30% in Spain, in the United Kingdom, in New York City, and in Detroit. And we think this is important because our health department in Chicago has reported a 2 to 3-fold greater mortality rate for Black Chicagoans, 161 versus 63 per 100,000 patient population. And this lower mortality, we think, argues against a biologic reason for higher mortality rates in African Americans, and is much more likely to be associated with a greater exposure because of more African Americans in positions as essential workers, and then a question of access to primary care and ongoing care for that patient population. And I certainly think more study is needed in terms of the explanation for the racial and ethnic disparities for COVID in our country and around the world. That brings me to the end of the session, and I see we have 13 minutes left for questions and answers. So I'd be very happy to take your questions and answers. And I see that there are a few in the queue, so I'll start with those and encourage people, if you have other questions, please do submit them. So I see a question from Michael Gill. For those gaining weight on an integrase inhibitor, do they lose it if they're switched away from an integrase inhibitor? Well, so Michael, I think that's a $60,000 question. The answer is we don't have good evidence that that is the case. And I actually want to share my own personal clinical evidence with you and then offer a way to talk to patients about it. So I've made a point of talking to colleagues, investigators who are also managing patients to ask this question. Have you had people in your practice who've gained a lot of weight with an integrase inhibitor where you then worked on diet and exercise without any other medication changes, where you've been able to either completely reverse or mitigate weight gain? And I asked that because I had my first 3 patients who had substantial increases in weight gain, who had weight gain with integrase inhibitors. In the first 2 cases, dolutegravir, and the last bictegravir. All of them were able to substantially reduce their weight with diet and exercise. So I've seen reversibility in my own clinical practice. So as I talk to patients about it, I will say that where there's been weight gain associated with these drugs that's reported on the internet, if you look, you'll find it. It's multifactorial in terms of its causes. Some of the weight gain is a return to health. That's very clearly established in the data from the Kaiser Permanente and from other sites. But there also is additional weight gain, even in people who are already obese or overweight, that's undesirable. And it's not clear, this is not like the lipodystrophy syndrome. So you just saw an example where it's not ectopic fat deposits or peculiar, it's not mimicking lipodystrophy, so that you can approach it with lifestyle changes. And that's my recommendation is, as you talk about this with patients, prepare them, because for all of our patients, an active lifestyle is a remedy for so many of the problems that are associated with HIV chronic inflammation and chronic immune activation. So I think that exercise and diet and healthy eating and living is something we should be talking to our patients about. There certainly is a lot of interest in this question about switching, and should there be, should we think about switching patients? I don't like the notion that that'll establish in people's minds that this is an exclusively treatment-related phenomenon. So I'd be very conservative about that. And then I might be selective. So you heard me say that in some patient populations, it goes beyond 2 or 4 kilograms of weight gain. And if that's the case, particularly African-American women are vulnerable to that in the advanced studies, then I would be at least willing to talk about thinking about a regimen change. Okay, so I see another really important and recent question from Martine. What are your thoughts on the STAT trial and the use of dolutegravir 3-TC for rapid start? I'm actually very conservative about putting my patients sort of at the front of the line for new treatments in this era. We have such a wonderful evidence base. So I was encouraged to see that there was, for the majority of patients in the STAT trial, people seemed to do well, but there was a handful of people where actually additional adjustments were needed. And so I'm pretty conservative. I think also rapid start is its time has come. It's leading to some very important advances, but I don't think it's necessarily required for everybody. So immediate same-day start versus rapid start in the first week or 2, I would be guarded about that. The current guidelines actually recommend, if you're going to do rapid start, you might want to stay away from certain regimens. You should probably not use a bacavir because you won't have an HLA-B5701 and you don't want to expose that patient to additional toxicity. You should probably stay away from an NRTI-based regimen because there's a lot of circulating resistance for NRTIs. And they go on to say the 2-drug regimen probably is not the best first choice when other choices are available until we have data like the STAT study and others. So personally, I will wait for more information before I put anyone in a rapid start setting on a 2-drug regimen. My argument there would also be it's simple enough to start somebody on a 3-drug regimen that's simple, effective, 1 pill once a day, and then to further de-intensify if you think it's reasonable, if there's other evidence to support it, if a patient particularly wants it. Great. So the next question from Delilah says, can you summarize the HIV risk for COVID, please? So the case that I'm making in the United States is that the risk of acquiring COVID and the risk of severe disease is identical for a person with HIV and for anybody else. So I think, the 3 W's are the answer to how do I prevent me and my family, my loved ones from getting HIV. I'm going to wear a mask pretty much all the time. I'm going to wash my hands regularly 3 times a day. And then whenever I change venues, I go to the grocery store, I go to work, or I'm at a friend's house, or whatever interaction is happening, wash your hands or have hand sanitizers between those. And I maintain the safe social distance of 6 feet or more, since we hear now that aerosol can transmit this virus. I also think for health workers, all of you who are listening, there's really good evidence now for eye shields in the workplace setting and in a setting where there might be greater aerosolization of fluid, and where there's intubation or an bronchoscopy or endoscopy. So I'm convinced now that the data on eyewear is useful enough that it should be done in health worker settings. If you were to fly on an airplane, it would be reasonable to have a mask and goggles. If you have to use public transportation, as many people do, and you want to protect yourself, wear a mask, certainly. Try to maintain 6-foot distance, certainly. And wearing goggles, I think now has become a reasonable activity. I really appreciate the question. I hope everybody can continue to protect themselves and others until we have a vaccine. And I think, we're likely to have an effective vaccine next year, and it's likely to be rolled out and widely administered within the 12 months of next year, but certainly not in such rapid speed. So let me turn to the next question. Melanie says, given the longer washout period with the long-acting cabotegravir and rilpivirine, you're right, longer even past 365 days, is there still a rationale to do an oral lead-in to verify tolerability of the drug? I think there is. I think that's a very important part of not only the clinical trials, but of our use. Because, and the argument that I'd make is, we know from drug allergy and the penicillin experience, nobody ever died from oral penicillin, or even it's only been either injectable or intravenous penicillin that's led to fatal drug reactions. So in some ways, this is a question about the known toxicity of this regimen and the unknown toxicity. And so to be very careful, I would prefer as a clinician for my patient to have an oral lead-in where I see their body's response to both cabotegravir and rilpivirine with a well-controlled 4-week period to see if there's any idiosyncratic, unusual side effects. And then when they are satisfied they've taken it and they're tolerating it well enough, then to start going with injection. So I really appreciate the question. I think the long tail is one of the more difficult parts of managing patients. So each of you, if you're planning to treat patients with this, should have a plan in your practice area for what are we going to do when we stop the medication, how are we going to monitor and follow patients to ensure that they're protected from the development of drug resistance, so that's one issue, and we maintain care and support for those folks because of that year-long tail. And a question from Mark, raltegravir has shown less effect on weight gain than other integrases. Correct, that is correct. Those studies that have compared the 3 have shown that it's greatest with dolutegravir, to a lesser extent, and actually bictegravir, though we have a little less data on that. Raltegravir, alvitegravir seems to be in the middle, and then raltegravir appears to be the least. Is it a better choice for those concerned about weight gain? Yeah, I don't think so. I don't think this will change the guidelines preference for those second generation integrase inhibitors with a higher genotypic threshold barrier to resistance. So they haven't made that switch yet. That data is out. And so what are the arguments in favor of the second generation? Well, it certainly is the degree of virologic suppression and the infrequency of resistance. So a much more durable effect. They're co-formulated and simple to use. And as you know, raltegravir at least has a once-a-day regimen, but that's a three-pill once-a-day, 3-pill once-a-day regimen that's a little bulkier. It's not quite as simple as a single-tablet regimen. So, raltegravir is an excellent drug. It's been maintained in the DHHS preferred guideline list because of its preference in pregnant women for so many years. So I think it's a perfectly good choice, but I don't know about better choice. I think everybody's somewhat concerned about weight gain. And I think you hear me saying for most patients, the degree of weight gain, 1, 2, 3 kilograms for the majority of patients, that's, first of all, not so different than what's happening in the HIV negative population, where the entire population globally is increasing weight. And certainly in our country, in the United States, we are living in the middle of an obesogenic time where people are gaining weight for a variety of reasons. So I would assume all of our patients are concerned about weight gain, or if you ask them, they'll say that. I think we should still strive for durable virologic control with the best tolerated, simplest regimen. That's the proper goal. And I think raltegravir is a great drug. It has lots to go with for it. But given the other options that are out there, I think I personally would recommend that you follow current guidelines for initial therapy and for first switch, because there's a strong evidence base for all of this information. And I think we can do better than raltegravir-based regimens.
Thank you, Dr. Sherer, and thanks to listeners for joining in. As a reminder, to view the full HIV Glasgow 2020 virtual conference coverage program on the Clinical Care Options website, click on the link in the show notes. Please be sure to check back regularly for more episodes on important infectious disease topics. Thanks.